lenses and the small eye. Because of the short axial lenses and the small eye they have when they born. However, this hyperopia reduces in magnitude toward emetropia around 3 to 5 years, and we will talk about this process in the future slide also. 30% of them, they born with anesiometropia less than the 3 diopter. If the anesiometropia less than 2 diopter, it's going to be emetropized in the first year of life. If it's more than 3 diopter, unfortunately, it's going to be more stable and less likely to emetropize. 70% of them have astigmatism. They have a steeper cornea. However, it's going to be less than 3 diopter at birth. 2/3 of that astigmatism will decline over the first 2 years. Unfortunately, the oblique, if it's less common, however, if it's there, they're going to be stable with the rule, have a greater chance to emetropize if they have that type of astigmatism. So that's the future of the visual system of the children on the first, especially the first 5 years of life. We need to also to know. We said also we need to know the normal values of visual acuity, refractive error according to the age. We will talk about the age group that we're going to talk about. It's going to be less than 1 year, 1 to 3 groups, and 3 to 5, and the school age children in our talking. This is the visual acuity norms in pediatric populations. In the first month, it's supposed to be 2400 or 6200. At the age of 1 year, they're supposed to reach 2060, and around the 5 years old, they almost be as the adult level of visual acuity, which is 2020. So that's the visual acuity norms that we have. So if you have a child 1 month old come with a visual acuity list or more deeper than 2400, you know there is something wrong. And around 1 year, if they don't have the 2060 level of visual acuity, then you know there is something wrong is going on with the child, and you have to take care or manage what the child have, do examinations and find out what's the problem. We need to know also the normal range of refractive error with age. We said that when they born in the beginning, they're going to be hyperopes around +2 to 4, or maybe even up to 6. And some of astigmatism, less than 2 diopter, and some of anesiometropia between 1 to 3 diopter. That's acceptable in the first year of life. 3 to 6, the process of the ametropization supposed to be almost completed at that age. So they're going to be around hyperopia was up to 1.5 diopter, that's acceptable. Astigmatism around 1.5 diopter, and then anesiometropia less than 2 diopter, and that's going to be acceptable during the examinations. However, the child need to be monitored if this spotted in the early. After 6 years of age, it's mostly ametropic, so they're supposed to be reaching the normal situation of the eye. However, sometimes if spherical refraction plus 0.5 diopter or 1 diopter around 5 to 6 years still there, that means they're going to be emetrope on the teenage years. If there is more than 1.5 diopter, they're going to be hyperope, and if they have myopia around 5 to 6 years, then they're going to shift to the myopia after that age. We also need to know the age-specific visual needs for this kid. We know that the child in the school need different requirement of level of visual acuity than the child who was still baby. So in infancy, they are interested in nearby objects, so they look at the face, close toys. They are farsighted. We know that they are hyperope, and because of that, shorter eye lenses. When they are between 1 to 3, they begin to explore their environment, so they need the coordinations between their visions and their movement, such as hand and eye coordinations. So they need good visions for their learning and play through this time. Preschool, 3 to 5, nearly almost now we said around 5, they're gonna have the 20/20 vision of adult. They start to engage in activities requiring fine visual skills like drawing, bubbles, and recognizing letters. So they need that level of visual acuity. If the child come to your clinic has a reduced visual acuity that age, then you need to help them to get that 20/20 because it's very important for their daily activity. The school age children, 6 to 12, they need at that time they need that clear visions because they get to be succeed in their academic task. The adults then their visual demands intensify as academic activities require to stay in focus and attention. So you need to work with them to push them toward that level of visual acuity. We said also we need to understand the immetropisation process. So what is the immetropisation? Is the process by which a normal eye has coordinated growth of its refractive component during early childhood to reach refractive near plane. We said that the kids born with hyperopia, so the eye lens and the refractive power is not matched, so that will give a blurred retinal let me remove this spot. Blurred retinal images. So because of that blurred retinal images, and there's going to be a field of accommodations that I will try to make accommodations to make this clearer. So according to the feedback from the accommodations, the physical changes are going to happen to place the retina at the correct focal point or the image, and then the eye will grow either longer or shorter to compensate for that blurred images. The eye changes from ametropia, so whatever is initially hyperops or myope, to low hyperopia or emetrope if it's happened. That's the normal development that should happen if there is nothing wrong going on with the child. These changes happened rapidly in the first year. So again, a significant visual development occurs in the first year. So it's going to be fast. However, it's going to be a little slower, around 1 to 3 years. It's rapid, but a little slower than the first year, and then it will be more slower around 3 to 5 or 6 age of years. So it's very critical and very important to take care around those kids in this early stages. So the disturbance of ametropization process, so the ametropization process itself could fail for many reasons. However, the most effective one is the unnecessary refractive correction. So animal study shows that induced refractive errors, they close their eyes or they put lenses in front of eyes. They found that this will lead to changes to the axial lens in adaptation to the new induced refractive error and defocused retinal images. So that the eye start to change itself to compensate for that changes that they got for the kids. For the animal, and then the animal end up having a refraction problem because of that experiment. So giving unnecessary lenses will permanently alter the normal development. If they give them minus lenses, this will position the focal point behind the retina, and then the eye will elongate, and then the child would the patients or the animal will end up having myopia. Giving them a plus lenses will inhibit the growth of the eye, and then the eye will become shorter, and the child will end up having hyperopia. So it's very, I mean, the animal that have the experiment will end having hyperopia. Also, studies on the children shows that immetropisation, if it's disturbed, if the refraction is necessarily corrected. So, for example, if the hyperopia corrected, it will not decline, and then the child will end up having wearing glasses for the rest of his life. So you have to be careful if you want to interfere to correct the refraction the child have during the early stage of the development. So is the child going to be hyperope or myope? It is not known. The disturbance of the metropizations could take the child toward hyperopia or myopia. What's decided? This is the biometric or optical factors such as the eye shape and the lens curvatures, genetic factors that lead to eye growth variations and refractive changes the child could have, and the environmental influences such as the light exposures and the sustained indoor activities of the child. So we cannot pretend or figure out which direction the refractions will be because it's controlled by different factors as you see here in the screen. So the main tool to predict immetropisation, I'm sorry for that screen, that's something covering the string, but it's that announcement of the entrance of the individual. I'm welcoming them, but I'm trying my best to remove it each time it comes. Now, the main tools to predict immetropisation is to monitor the child development. We cannot predict, as we said, it's going to be hyperop or myop, it's going to be worse or less. We cannot predict this. We just follow the development of the child and direct the development toward the correct way so that we get a successful immetropisation. For the successful immetropisation, we need to have a healthy ocular structure for the child. We need to give him check that intact process the child have it, the operational refractive ranges the child should have, and then a healthy environment so that we're gonna direct the development toward the correct point. And we will understand from the next slide what I mean with directing him toward the correct point for development. Their refractive level for each age. So when you spot a child in your clinic having different visual of level acuity according to his age, or having different prescription according to his age, then you need that child to be have help or management. Talking about the guidelines. Okay, so all the well-known associations, they have given their own opinion regarding the taking care of the children. You will find a lot of brochures and different articles regarding this. However, the clinical experience of the clinician himself and his personal decisions will play a major role in determining and managing refractive status of the child. You are the one in the clinic who see the child, the need of the child, the condition of the child, what else the child has with that refractive state, and then according to your experience, you can mainly decide what to do for that child. However, you're going to follow the guideline, but it's not a straight line. It's not like a red line that you should follow. Otherwise, you are doing something wrong. It's a guidelines, and then your experience will be also added to the management method or treatment plan. So the treatment plan, which should be adjusted should be adjusted for each child according to his immetropisation process stage, according to his age, the visual need. Definitely the child who is 10 years need different requirement of visual comparing to the child of 1 year. According to his refractive defects that he have, the hyperop child will be having a different management than myopia. The associated condition, if he have a strabismus or myopia, anisometropia, if he have accommodation problems or binocularity problems, and the general health or the ocular health, all this is going to affect your decision when you are going to prescribe for the child. And you also should consider the previous glasses and the current, the one that he wears, or the past issue he has with the glasses. Maybe the parents said, well, the child does not wear the glasses. They wrote, give him a glasses, but he doesn't wear it. And he doesn't want to wear it. And then you have to ask why and see what was the reason for the child rejecting the glasses. Maybe the glasses was not good, or the the child doesn't like the design of the glasses that they give them. So you have to consider all these things when you are working with a child. There are some rules of the thumb when you're working with the child in your clinic. We all know this, but I'm going to put it here. We don't ignore any symptoms. If the child have 20/20 sight and he have complaint, that doesn't mean that he has no refraction. Maybe the child have a refraction, but he is overcome this by the accommodation, and that's why he have symptoms, even though if his visual acuity is 20/20. If you have a minor symptoms and you don't want to interfere because it's a minor symptoms, then you need to have a regular assessment through until the child reaches the 7 or 9 years of the age. And during the examinations, you have to try to gain trust of the child. If you gain the trust of the child, you're going to have a very pleasant examination or test with the child. And I found it that it's very important to make an eye contact with them. If you make an eye contact with them, they will listen to you and they will go ahead and give you what you want. The other things that is very important is to make your clinic or your area is a child-friendly environment, so the kids will enjoy the place and enjoy coming to the clinic. Honestly, I have my clinic arranged to be child-friendly. I'm going to show you this video. So, uh, the clinic, my clinic is arranged in a way that the kids like it, and then the encouragement and encourage the child to follow your treatment and do what you want from them. Okay, the other rules of thumb, the thumb is the need for the cycloplegia. We never refract a child below 12 years without cycloplegia, especially in the first exams or first visit, because we want to rule out any latent components, especially esotropia, and we know that they have a large amount of accommodations and variable accommodation. It can reach up to 12 diopters. So you have to be very careful with those kids, unless it's a follow-up child that you saw him before and make a cycle for him. Any new child, you have to do the cycloplegia, especially in the first visit. It's very important because it's going to affect the. Sometimes you're going to have you could have a child with a -2 diopter, and then with other symptoms that could tell you that this child has a problem. And then when you dilate him, you'll find that he's actually hyperope that over accommodates and become minus. So it's a pseudo myopia. So it's very important to dilate the children with the cycloplegia, especially in the first visit. Again, potentially amblyogenic situations. You are thinking that child could have amblyopia, then you need to be having a cyclorefraction. It's very important. If you have a visual, sometimes you have a visual acuity from the child, but it will be underestimated because either the child is unhappy, he was bored, or he was sleepy. So he will give you a level of visual acuity is not suitable or is not acceptable. And then when you do the cyclorefraction, you're gonna have some way of understand or estimate the level of the visual acuity of the child when you see that refraction or result of the refraction with the cyclopentolate. Be a cycloplegic method. You also need to do the cycloplegic repeated annually because you know the child is growing up. Then each year you need, if there is no problem, you need to repeat that annually to find out if there is any changes, or if the visual acuity decreased during the management, you want to find out why, or if there is no improvement with the treatment, then you need to cyclo or make a cycloplegic refraction for the child to find out what's the problem or what's going on with that child. The ideal cycloplegic drug characteristic, it should be easy to administrate. It should be adequate, give an adequate cycloplegia so you didn't find any reflexes when you check their dilatations. It should be a quick, honest, so that you can use it in the clinic and give a quick result with a minimal side effects on the child, and it need to be reversible in a short time so that the child will not stay there suffering from the effect of that medicine for a long time. This is a schedule with the different type of the cycloplegia you can use in the clinic with their dosage and the peak effect, the duration, and the post-cycloplegia test that they need. I found that if the patient has no deviation, you can use a cyclobentalate in the clinic, which is a gold standard medicine. However, if the child have deviation, then I don't trust the cyclobentalate because sometimes you're going to find some effect hidden or some refraction hidden. You need to use an atropine, which will be 3 days before the examination. And you have to be careful because incomplete cycloplegia could lead to over or underestimation of the refractive errors. You have to be sure that the child have a fully dilated pupil and no reaction still there before examining him. The other things you have to understand, put in your mind that you don't need to bring the child again for subjective refraction because those children will not give you any reasonable or reliable result on the subjective refraction, so you don't need to bring them back again. Sometimes you can do a quick revining or verifications when they are dilated by just putting them on the chair, ask them to look at the board and try a quick subjective refraction on them if they respond, or you don't need to bring them back to the clinic. Again, as we said, the selection of the cycloplegic should be according to the age, type of the child have, the symptoms, the iris color, because the dark color need stronger dilated medicine, and it's central nervous system disorder. You cannot give them cyclobentalate. You should give them. I don't ask if the sound is okay and everything okay. Everything is okay, Dr. Lama?
Yes, it's all okay.
Okay, thank you very much. Any questions? We are reaching here. Do we have any questions? Any important questions? I know all the questions are important, but we don't want to interrupt the lecture unless we have something gonna fit or benefit for everybody. So nothing there?
I believe everyone is
Dr. Lama?
holding the questions for the question sessions.
Okay. So then we will continue. It's important to warn the parents about the systemic side of the medicine. We know that all the medicines that we need, we use for cycloplegia, could have a side effect, and we know that side effect. So you have to warn the parents when you effects while and really I spotted or I have facing the side effects with some kids during my work 2 times during my working periods. One has a hallucination. It was very horrified hallucinations. We take them to we rush them to the emergency room to give them the antidote for that medicine. So it was a cyclobentalate. However, the child has a very horrifying hallucinations, make him cry all the time, and he was afraid from everybody. I think he was seeing, for as he was said, he was seeing us as a monster. So it was a very sad experience. Also, the flushing and the allergic reaction from the medicine. Also, I see one of the I saw one of the patients has that. That reaction. So you have to be careful regarding this, and you have to warn the parents that this could happen. And when you do it, you have to be sure that there is there's some people around you that can take care of the side effect of the medicine if they happen to the child. If you are unable to use the cyclobentilate or any medicine for dilatations, you can use other methods such as the contralateral fogging technique, where you put a +5 diopter in front of the non-examined eye and do your retinoscopy, and then you shift the lenses to the other eye and do your retinoscopy too. But it's not going to be as effective as using the cycloplegic medicine. Okay, now we have a dilated kids. He was agreed. We put the dilatation drops. Now he's ready. The pupil is fully dilated and everything is okay. Now you don't want to do the retinoscopy for them. It's again the preferable technique using the retinoscope. I don't recommend it using anything else. The automated machines are not going to give an accurate or reliable result. However, if you are forced to use it, then that's okay. But the retinoscope is going to be the preferable techniques for doing the refraction. It's going to be very hard, very difficult, but I found that some things or some points you can use during this. The first thing is to give out or take out the lab coats or the white coat before going into your clinic. I usually use different clothes. I use the clothes with pictures for the kids, such as their cartoon characters and other type of the pictures on the clothes. So the kids will like it. They will ask about it, and then we will have a chat about this until the child comes. So it will be a very big helpful if you do that. Again, you need to have a lots of toys because the kids will be concerned about the things that they didn't know. But whenever at the point that he see it, it will be or grabs their attentions. You have to be creative. Sometimes you have to be silly, and sometimes, however, you have to be insistent and you have to be professional, quick, and don't give up with the child until you get that refraction because the child is already dilated and it's not acceptable to send him back without doing the refraction. There is no place like home. I found it easy to do the retinoscope or do the examination or the test for the small kids by making the parents holding them, hugging them, and calming them. They will feel safe and comfort in their parents' laps, and you can do whatever if you want. They can give you that beautiful, innocent looking while you are doing the examinations. So, carrying them, asking the parent to carry with my muscle lights and do the examination for them while they are looking at me. So it's going to be struggle. However, the end or the result will be very rewarding. So now you get the refraction and you think, do these numbers need to be corrected? What's the action I should take regarding these refractions? However, you need to remember that what you decided for the child now will stay with him for life. So if the child, during the maturization process, you have to think twice before giving the refraction to the child. And you need to act according to the knowledge or information that you know about the metropizations, the level of the visual acuity, the level of the refraction they should have according to the age. All these things should be in front of your eyes to take your decision or make your decision regarding the refraction. Okay, so the correction for the refraction goals should be providing a focused retinal images. So you got to improve the visual acuity of the child, which will make the accommodation less. I mean, the demand for the accommodation will be less. Having an optimal balance between the accommodations and the convergence so that the child will have a comfortable vision. The corrected deviation if it's presented. So we're gonna reduce that esotropia or exotropia if there, improve the binocularity of the child, and optimize the visual functioning. So they optimize the hand-eye coordinations and for example, the peripheral vision of the child, and reduce symptoms if the child have it, such as the stenosis, headache, and so on. Okay, so our corrections will be according to the answer to these questions. I have 4 questions. We will see how we're gonna work with this. The first question is this refractive error normal for the age of the child? Visible in your brain. So if within this range of up to 4 diopter in the first year of age, you will not take an action and will not do anything. However, if it's more than this, then you will think twice before. We answered the first questions. Is this refractive error normal for the age of the child? By saying that we need to know the normal refractive range for the child of that age. If it's more than the range of the refractive, then you consider working with the child doing refraction, and we will talk about what we will do if we decided to give a correction. The other question is this refractive error amblyogenic? Is it gonna affect the child, give him an amblyopia? If we look at the schedule here, this table, I make it so that it's going to be easier for everybody to spot the thing. If the refraction, let's say they have an isometropic refraction, if they have if they are more than, if they are hyperope and have high hyperopia, it should be, you correct them if they are more than 5 diopter. For the cycloplegia, I'm talking with the isometropic refraction where both eye have the same refraction. If they have astigmatism more than 2.5 diopter, then you need to refract them. Sorry. If they are an anesiometropia where one eye is different than the other eye, fraction is different in both eyes, then the number to be corrected will be less. If they are myopic more than 3 diopter, then you need to correct them. Hyperopia 1 more than +1, you need to correct if they have anesiometropia. And if they have astigmatism 1.5 diopter with the rule 1, or if they have oblique 1 diopter, need to be corrected. Again, also hyperopia with esotropia need to be corrected. Myopia after the age of 2 years, if they have a refraction, need to be corrected. School age children who need the 20/25 vision, if their visual less than 20/25, then even if they have a myopia more than 0.5 diopter or more, you need to correct them. And if they have astigmatism more 0.75, then you need to correct them because they need a very clear images in their activities, okay? Anyway, so we said if you find a refraction that the child have anesiometropia, then the correction of the refraction that they have to be more urgent than if they have isometropia. And we will talk again in the few slides about this. So we will continue. The other questions that you should ask yourself, will this refractive error emmetropize? Is it going to be emmetropized? Is it during the emmetropization process and it will emmetropize with the time so that I will not interfere? Then the study said that if the refraction is high, high refractive errors are less likely to emmetropize. And this is the level of the refractive error that you can consider it high. So high hyperopia more than +5, high myopia more than -6. So if the child have a high hyperopia or high myopia, it's unlikely to emmetropize. So that's again the question that you should ask yourself. So we said if it's high refractive, then will not emmetropize. So, and also refractive error outside the normal range for their ages will not emmetropize. If they have higher level of anisometropia, more than 3 diopter, then you have to interfere because this is will not emmetropize in a proper way. If the child have a low vision, then that's mean he will not emmetropize. Yes, we can take our treatment management or our management plan according to what the findings. So we're going to talk about this, but I'm saying that when you do your refraction and you find you find the refraction one of this, then you know that the child this refraction will not emmetropize in a proper method. So you have to take action or you have to take management. The other thing is that the if the child have a strabismus, if there's a deviation, when you do a refraction and the child have a deviation, then you need definitely to refract I mean, do give a refraction or a glasses for the child. I'm sorry for the disturbance that's happened, but it's not from our hand. Thank you very much for being patient with us. Um, okay, so we're going to go to the next questions. You should ask yourself, will this refractive error interfere with the normal process of emmetropization? Okay. And then, yes, it will. Refractive error, if it's the level of the effective, it's going to affect the abnormal focusing signals that go back to the brain, which said to the brain, elongate the eye or shortening the eye. So this is going to disturb the normal eye growth and then hinder the emmetropization. Again, it could affect the feedback loop interferes, whereas the accommodations, the accommodations happen to send the signal to the brain. It's going to affect that loop and then improves eye adjustment and then hinder the emmetropization process. So you need to be careful because preschool children, they are through that, within that range of changes. So corrections could interfere with their normal process. You have to be careful. However, the school children, metropization is almost completed. You have then, when you want to deal with them refraction, you have to consider their educational mandate to correct when you correct them. So you answer your questions and you find out that the kids have a refraction need to be corrected. There's general rules you have to consider before you're doing that. If the child is less than 2 years, you need to monitor the refractive error about 4 to 6 months before prescribing for the child because it's going to be changed or it could be in the mode of the child, could be a normal abnormal refraction or I thought error refraction. That's why you have to monitor the refractive error for the child before you prescribe for him. If they have a small error, there is no corrections because we know that during these ages, they are during the metropization process. unless other factors outweigh the need for the stimulation of the metrobization, such as strabismus or anisometropia and so on. If no corrections for the small error, you decided not to interfere, then you have to check the accommodation, should be measured to be sure that the child has no over or under accommodation process. You can use different methods such as the monocular estimation methods for retinoscopy or the accommodation test to find out if the accommodation level, because then the child need sufficient amplitude of accommodations to overcome hyperopia and near task when they're doing. If they have any ampliogenic risk factor, then you have to deal and go on do partial or full corrections according to the need of the child. And we will see this in the future slides. Sorry. If you decided to give a child the correction, then you aim to bring the uncorrected portion of that refraction just within the normal range for the child age, because we don't want to correct the complete smooth and making the process, the metrobization process stop. Because if you correct fully and give the child clear images, then the brain the retina will send signals to the brain that, okay, the image is correct. I can see clearly, stop the changes. So we don't want this happen. We need to give them something helping them, but in the meantime, also giving them space so that the metrobization process continue. If they are large errors, if they have a large error should not be fully corrected. You convert them to small error according to the mean for the ages. And then that will allow them to proceed, with the metrobization process. If we decided to you detect only the sphere, you give less plus or more plus or minus because according to the condition that you have. However, you give them the full cylinder if they have astigmatism. So we don't cut from the astigmatism. We give them the full astigmatism and cut only the spherical amount. If they have an azometropia or strabismus, then there is no any under corrections. We give full corrections. We don't concern about the metrobization process because the strabismus or the anisometropia will make that I'm sorry. The screen is covered. You can see it. We will go back. Okay. After 6 to 7 years, now the metrobization process is complete. You may do full correction. We give a refraction, but however, thank you very much. I'm sorry for what's happening. I don't know why this screen comes all the time in front of me. Anyway, as we said, after 6 to 7 years, you can do full correction because the metrobization process is finished. But again, it need to be according to their age and according to their demands, as you find in the previous result charts. Refraction should be carefully rechecked annually and when the changes happened. As we said, you have to yearly do refraction for them, a wet refraction, to be sure that there is no difference or changes happening during the growing up. And if there is any change on the level of the visual acuity, then you're going to do a cyclorefraction. And the glasses should be prescribed based on the visual acuity testing at distance and near. You should consider both distance and near when you are giving the child the glasses. I have to remove this so you understand what I'm talking about. The follow-up or the re-examinations the follow-up or the re-examination interval. You should examine patients at the most appropriate interval, depending on their clinical finding and needs. So the follow-up should be parallel with the problem the child have. The younger the patient, the higher the refraction, then the shorter the intervals between the follow-ups and vice versa. So when the kids becomes less and less and more stable, you can start to make a long interval for the visit. However, when the child is having a problem, you have to monitor them closely in a short interval visits for the follow-up. The other things is you should consider always binocular balance between the two eyes. Always maintain binocular balance as possible. You also equalize the accommodations. You do retinoscope binocularly and see if they have the same reflex coming for both eye from the same distance. You want to be sure that the accommodation is equal in both eyes. And then for correction of the anisometropia, then again, respect the difference between the two eyes. If you cut the corrections, you have to cut it from both eyes at the same time. And we will talk about this also. And yeah, for the cataract, if you remove, yes, I think I prefer to put the lens inside the eye, but if it's valuable, that's I'm answering one of the questions. Because you will get the child out from that thick glasses and or contact lenses if they need it. So yes, I prefer to give the child intraocular lenses with the surgery. And I think there's now they have lenses that can fit the child and stay with him for life. I'm sorry for what's happening every time the screen is closed in front of me. لما دكتورة لما
Yes.
بتشوفوها السكرين السوداء هذه ولا بس أنا؟
Yes, we can see it from here. I think you just need to close it to go back to the same presentation.
If I want to close it, it will say that leave the meeting. Okay, it's gone now.
Okay.
Thank you very much
Very
for
good.
answering.
Yeah.
Thank you. Oh, it backs again.
It is good from our side, I think.
Okay, there's
it
a
came back.
questions. Please answer these questions. 4-year-old child present with diagnosis of esotropia, and you have prescribed spectacles with a high plus power to help improve their vision and reduce their symptoms. However, the child parents are concerned about the patient risk of high plus power spectacles, including the risk to, let's see what's what are the potential benefits and drawbacks of using high plus power spectacles to treat esotropia in young children, and how would you counsel the parents on the most effective treatment approach for their child? We will answer these questions during the next slide. So just be patient and follow the lecture.
Doctor, I think the screen is blocked now. We have a square in front of us.
Is it now it's there?
Now it's visible, yes.
Okay. So we talk about the balance. We do the balance. We have to be careful about balancing. We know different method of doing the balance, like the dichromes and everything. It's according to the child age if you can do it, but you have to be careful for the balance between the two eyes. Now, with doing the refraction, we're going to deal with the refraction in two different methods or two types. If the child have a strabismus or if there is no strabismus with the child. So the without strabismus, how we deal with the corrections, and if the child have the strabismus, how we deal with the correction. First, we will talk about if the child have a strabismus and a refraction, so almost full correction to support eye alignment and prevent further deteriorations. It's a very straightforward method. I will talk here. I make a summarize. So refractive error with esotropia. you almost give full cycloplegic refraction because we need to relax the accommodation. So we may overblast the child to relax that accommodations and make the eye go straight. If the child have myopia with the esotropia, then you're going to give them a minimum minus. If you have a hyperopia, you're going to give them a maximum plus to make that eye straight. A refractive error with exotropia, you also give almost full cycloplegic refraction. So if you have a child having a refraction and he has an exotropia, then you're going to give a full cycloplegic refraction, not a dry refraction. We need to, in this case, with the exotropia, we need to stimulate the accommodation because if the child make accommodation, that exotropia with the converging effect will be less and the eye comes straight. If they have a myopia with the exotropia, then maximum minus give to the child so that he can accommodate and then the eye will go in. If he's a hyperope, you're going to give him a minimum plus so that he will accommodate and make that eye come inside or become straight. So that's the rule. If there is a refractive error with strabismus, then you're going to give the full correction, okay? Even if the child is within the range of the metrobization, because that deviation will not make the metrobization process go in a proper way. So you have to jump in and treat the problem for the kids. So that's a summary of the refraction error in case of the strabismus, okay? Now we're going to talk about the same thing, refraction error with strabismus. Some point you have to consider with hypermetropia. If the child less than 2 years, you will not correct him until he's more than 3.5 diopter. For elder children, they should be more than 1.5 diopter to interfere and do their correction. But as we said, should be a full correction. The hypermetropia often associated with strabismus and high ACA ratio abnormality. So you have to consider this and check the child to be sure there is no, you have to consider this when you have hypermetropia. If they have anisometropia, more than 1 point diopter, they have to be corrected, full correction. If they have astigmatism or amblyopia, then full correction for optimum visions. We may push plus to control ESO if the child have it to relax accommodation, as we said, and we cut plus to control the exo to stimulate accommodation, as we said before. If the child has near ESO or lack of accommodation, then you may need a bifocal, then you can give them an ad, and then if you give the ad, you need to also follow the child to try to reduce the ad as soon as possible because we want them to rely on their accommodation. And we will talk about this in some details in the future slides. You have to think about the accommodation with the hypermetropia and the latent hyperopia if it's there, and the visual acuity and near and distant. And this chart here is a summarize of this or what I'm saying here. So if the hyperopia have an exodeviations, then minimum plus given to them with best visual acuity. However, that's an uncommon condition, and you need to be careful with this, and you check a neuro. Maybe the child have a neuro problem because having hyperopia with exodeviation is not normal. So maybe there is something wrong going on. You have to check. I would refer the child to the ophthalmologist to check the neuro problems if the child have it, or to the department that is in charge about the neuro problems with the kids. If they have hyperopia with esotropia, then we said full correction. We'll give them maximum plus. If they have a near esotropia, then you give them minimum ad, and that should bisect the pupil. And we will talk about this in the future slides also. In case of myopia, less than 2 years, you don't correct them and then they are more than 3 diopter. That's in case of strabismus. We said if there is no strabismus, will be different, but this is with the strabismus. If they have 3 diopter or more, then you correct them. Children older than that age, they should be 1.5 diopter or more to correct them, or if their visual acuity is reduced more than 20/30, they should be fully corrected. And you be careful with the myopia because minimum correction need to be given. So to give a maximum visual acuity should be the aim, because we don't want to overcorrect them, and that's may causes accommodation spasm for the chest. So you have to be careful. We don't want to give them a spasm or induce hypertropia with overcorrecting them. If they have anisometropia more than 10 diopter, they need to be full corrected, and if they have astigmatism also. You may cut to minus to control the ISO. So we relax the accommodation, as we said, or we push minus to control exo to stimulate accommodation, as we said before. Again, this chart is here explaining everything in a proper way. So myopia with exodeviation, maximum minus for best visual acuity, and then you want to overcorrect them to induce convergence. Myopia with isodeviations, you give minimum minus for best visual acuity. You want to undercorrect them to relax the accommodations. However, myopia with isodeviation is it's uncommon, and you need to be careful again because it could be some related to some neuro problem for the child. Okay, if they need an add, you're going to give them minimum add to control the near isotropia or the lack of accommodation. Okay. In case of anisometropia with strabismus, you find they have anisometropia when you do the refraction for the child. It's a risk factor for amblyopia, so you have to be careful. If they have anisometropia, they need to be having polycorrection, cycloplegic corrections. If you do the correction, then you have to maintain the difference between the two eyes. So say if you have 3 diopter and 1 diopter, then you have to maintain that difference. If you reduce the refraction, you want to reduce the refraction for any reason, then let's say you make 2, then you have to take off that one from the other eye. So you have to maintain the same difference of anisometropia between the 2 eyes. Okay. Again, you don't be if the refraction is more than 3 diopter, I think giving a contact lenses for the child would be difference between the 2 eyes more than 3 diopter. I think it's better to give the child a contact lenses because this will give him a better binocularity. And don't be worried because the children can tolerate anisoconia much better than adults up to 7.5 diopter. So if they have like different 7 diopters between the 2 eye, they can tolerate that. However, you will be helping them through that process to tolerate that. Or if you find that it's difficult for them, then you can reduce until they reach the suitable or the comfortable situation. Again, you have to be careful about the binocular visual acuity and near and distance, not just near or distance. And the stereo acuity should be noted during the treatment or management method. I put this also in the chart, so that's going to be easier for everybody. Anisometropia, if they have that, so we have a unilateral. The good eye is in control of accommodation, so you have to consider this. If they have more than 3 diopter, we said we correct them and we want to make the image clearer for them at near. If they have astigmatism 1 diopter, 1.5 diopter for with the rule, and if they have oblique 1 diopter, then you need to correct them. Hyperopia more than 1 diopter, you need to correct them because the more hyperopic eye is a pluri eye, and then the child could have amblyopia in this eye. So if there is a difference between the 2 eye, more 1 diopter in the hyperopia, you need to correct the child straightforward. If you have astigmatism with the strabismus, that's the chart for treating or dealing with astigmatism. If the child have astigmatism and hyperopia with ISO, then you give them maximum plus cylinder. You give them a plus cylinder and you give them a maximum plus cylinder to get out of that isotropia with the hyperopia. If they have myopia plus ISO, and then again maximum plus to get out of that, a maximum plus cylinder to get out of that myopia and ISO. Again with the hyperopia and ISO, minimum minus cylinder. If they have myopia plus exo, then maximum minus cylinder with the astigmatism. And you can take a shot screen of that screen if you want to deal with this type of refraction. Okay, any questions regarding this strabismus and this refraction with the strabismus? Any important questions?
We have one question here from the chat
Okay.
from Mr. Muhammad. If we give overcorrection in hyperopia with esotropia, so what about her distance vision?
That's why we said we have to make a balance between near vision and distant vision. So you have to make a balance. You put the glasses, see what the child see, and then you make a balance between the distance and the near. However, you need to give that maximum because you want to control that astigmatism. That's strabismus. Okay. So now we're dealing with the refraction without strabismus. So it's going to be simpler corrections, but the approach focus on getting maximum visual acuity. Our aim will be getting a maximum visual acuity with comfortable visual system or comfortable visual ability for the child. So I make again a chart so that it's going to be easier for you to connect. So now we're talking about refraction without strabismus, okay? Correcting the hypertropia if there is no strabismus. The hyperopic children will be visually impaired at near, and that's increase the high risk for amblyopia, and also esotropia could be there. They have a subnormal accommodation. So you can start with 2/3 of the correction because if they are during the age of the metrobization, and then you gradually increase if they need it. If you cut symmetrically between both eyes because we don't want to affect the accommodations and the binocular phenomena. If you undercorrect them, then it should be constant with the vision. If the vision is decreased, then you overcorrect. If the vision has increased, then you can undercorrect. So it's a balanced method, our trial method and the clinic. You increase and decrease until you reach the point that gives the child a best visual acuity and comfortable visual system. The reduction of the correction should be attempted periodically. When the child comes to your clinic every time, you try to reduce some of that hyperopia by like reducing 0.5 and see if the child is okay, feel okay with it, then you go for it. If the child said no, then you go back until he is ready to get that or reduct that part of the hypermetropia. The aim is we want them to accommodate by themselves. We don't want to overcorrect them and affect their ability to accommodation because they are still growing and the accommodation system need to be grow also with them. But if we give them the full correction and give them and correct them fully, they would not be able to accommodate by themselves because the image is clear for them now. And then I make the chart here so that it will be easy for you to spot the time or the level of the fraction error that you should do for the children. Sorry. So less than 1 year, you don't correct them unless they are more than 0.5 diopter. If they are 1 to 3 years, but those are still on the ametrobization process. So you don't correct unless they are 4.5 or more, 3 to 5 years, 3.5 or more. And then, as we said, we undercorrect them approximately about 1 diopter or 2/3 of the refraction because you want to stimulate the ametrobization process and not blocking it. For school age children, now they have no, they already finished the ametrobization process. Now you look at their academic task and their demand. So if they have more than 1.5 diopter of hyperopia, then you need to correct them. Or if they have symptoms, even if they are less than 1.5, they have symptoms, then you want to correct them. But you can undercorrect them by 0.5 so that to stimulate accommodation if you want. The uncorrected we can face sometimes we have face a problem with the child who is hyperop when you give them the glasses. The parents come to your clinic and said he doesn't want to wear the glasses, and he said that he see clearer more without the glasses when they compare. What's the problem is that the uncorrected hyperopic child overcomes his hypermetropia by doing more or extra accommodation, and the brain still going with this facility, and he did not recognize yet that they can relax that accommodation when they were in the glasses. So when the glasses first one, the accommodation may not relax immediately, and then this will make the child say, I can't see with the glasses, I don't want the glasses. You have to explain this for the parents and told them that when they first wear the glasses, they may not see clearly. You have to force them to wear the glasses most of the time so that they have that relax that amount of accommodation. If there is not gonna happen and the child still complaining, then you can reduce or cut some of the refraction and give it to the child, and then you start to reduce the amount of the refraction with the improvement of that accommodation until you reach the maximum amount of the refraction that you want to give to child. Or you can go use a course of cycloplegic drops that make them relax their accommodations. And when they use the glasses, they will see the difference that they can see clearly with the glass, and with the time that accommodation will be relaxed. Again, it's according to your um, uh, decisions and according to the trial method that you have it with the child in the clinic. But you have to wear toward the parents and told them that they may need to change the glasses many times, and they may need to force the child to wear the glasses because of that problem. Correcting the myopia, it's less risk for amblyopia because they can see nearly, so the amblyopia will not be a big challenge for us with the myopic children. So you prescribe for them according to the visual needs and their visual aid. The aim will be lowest minus for best corrected visual acuity. But if they have anisometropia or astigmatism, anisometropia more than 2.5 diopter, or astigmatism or amblyopia, then you will gonna go full correction. And you have to be careful. Again, overcorrecting them may cause accommodative spasm or induce hyperopia for the child. So you can use also one of the balance or balance examinations, such as the D-Chrome test, if the child are able to do it, to make a balance, or to get out of that over minus, if it can happen. Again, I put the chart here so you can see the amount of the refraction that you get, the amount of the power that you can refract. If it's more than 1 minus 5 diopter for less than years, then you go refract them. I'll give them glasses. 1 to 3 years minus 4 diopter or more, then you're gonna give the glasses or correct. If they are more than 3 diopter for 3 to 5 years, then you need to correct them. Again, you should consider the ametrobization process. So you undercorrect them. Either you give them the 2/3 of the amount or reduce approximately 1 diopter of the refraction. For the school age children, then you give them a full correction because we want them to see clearly, even if they have less than minus 1 diopter, or if they have symptoms. There is some consideration with the myopia. We give them glasses. If the distance vision worse than 20/30, we have to give the glasses. And if their visual acuity more than 20/60 with the glasses, without the glasses, you can tell them that they can wear the glasses for school and televisions only, not all the time. Because without the glasses, the visual acuity is okay, more than 20/60. So during the playing or the hard activities, you can tell them that they can put the glasses away and then wear it during school time and televisions only. If their visual acuity is less than 2100 without the glasses, then they should be wearing the glasses all the time. And you should explain this to the parents so they will help you in making the child follow your method or your procedure for treatment. You also should tell the parents about that ability of or being able or being force the child to have outdoor times approximately around 2 hours per day on average, so that they have relaxing accommodations and normal development of the eye, and they also need to limit the near work and the screen times during that age, because it's going to affect the metrobization process. Less than 2 years, they know they should not use a screen or look at the screen all the time. Between more than the age of 2 to 5, they should have only maximum 1 hour per day of the screen. So the near work should be as less as possible to give them a normal development during that metrobization process. And then you don't give any promises for the parents regarding what will the child have, or are he gonna get out of the glasses. You just said, I don't know, because the metrobization or the development process is not something that we can control, and we just follow and correct for the child or direct him toward the correct method of metrobization until the child finishes or grow up to the age of 9 years. So don't give any promises or any explanation to them that regarding if the child gonna get off of the glasses or not, even if the child have a small refractions error. Correcting the astigmatism. If the child has an astigmatism, we usually correct three-quarter during the emmetropisation process. So we want to stimulate the emmetropizations, and we correct them only if they have more than 2.5 diopter of astigmatism on the early ages. For the older children, as we said, 1.5 diopter or more, then they need to be corrected. You give them a maximum cylinder that can be tolerated, and with older children, you can give them an accurate access by doing refining for them. And you don't be worried, because the kids are able to adapt to a high power of the cylinder. So it's not like adult, they can adapt it to it. If they have amblyopia or anisometropia more than 2 diopter, then you need to give a full correction. You don't undercorrect. And you make changes in the glasses very carefully and conservatively. If the kid come to you and find that he was wearing glasses with an axis of, let's say, 15, and then you find that he need to be on around the axis 17, then you have to be careful in changing this, because they are very sensitive to the change of the cylinder and axis of the cylinder of the astigmatism. If you have oblique astigmatism, that's a very urgent or serious things, because it's an amblyogenic risk factor. So you have to correct early to prevent meridional amblyopia. They with a meridional amblyopia, they're gonna have a poor recognition acuity. They have decreased decreased half line of visual acuity, which is which is one cylinder of the one cylinder diopter with the meridional amblyopia. This is also a chart so that you can decide it. 3 diopter, more than 3 diopter, less than 1 year, then you correct. If they have more than 2.5 diopter of cylinder, then you correct them. 3 to 5 years. If they have more than 1.5 diopter, then need to be corrected. And if you want to undercorrect them, as we said, you may give them 3/4 of the correction, or you can undercorrect them approximately 1 diopter because of amortization process. However, with the school age children who have academic task requirement, even if they have less than 1 diopter or less, or if the child have symptoms, then we give them a full correction. Again, we have to be careful with the oblique astigmatism because it's a risk factor for amblyopia. Okay, this is if you sorry, got bug there. Let me go back. I want to show you something. We said here in the hyperopia, you always give with the astigmatism. I want to show you the table so you understand what I'm saying. Okay. Yes. We said always if we have strabismus, then full correction, full correction, full correction, full correction. That's the table that show you. I will show you this table later on, but I want you to see that if we have a hyperopia with strabismus, then we will give a full correction for the children at every age. But you consider how much is the refraction, then you start to do a full correction. Again, hyperopia with anisometropia with strabismus, you see here full correction, full correction, full correction. So it's very important to okay, so going back to our slide. Okay, so this is the hypermetropia, and we talk about the myopia, stigmatism. So that's a schedule, a complete schedule. You can take a screenshot shots if you want. That's recommended by the societies, the American Societies for Strabismus and Pediatric and the American Society for Optometry. That's our recommendations. And then I put also the recommendation of the undercorrected or full correction if you want, okay, again in the slide. And you can see here with isometropia, the number of the correction will be high, so +6 or more for less than year to correct. However, with anisometropia, the hyperopia, without strabismus, it's going to be 2.5 or more. So anisometropia, strabismus, going to affect your decision for the correction of the refraction for the child. So you have to be careful, and you have to be considering all this point or all these factors when you want to do a refraction for the child. I know it's a lot of information, but the main point is that when you have a refraction with strabismus, anisometropia, amblyopia, then you have to think carefully to give a full correction, even though if the child have immobilization time, because all those factors will not make the child have a normal immobilization process. It's going to affect the immobilization process. This is a huge chart with all the points, and on like age 1, age 2, 2 to 3, 3 to 4, and then the adults, and with a lot of information. However, I find a very short guides done by Dr. Ayman Al-Ghunaimi. It's very important and very helpful. He collect the kids in groups and make it closer. So 1 to 3 years age, if they hyperope, then you don't correct them unless they are more than 0.5 diopter. If they are myope, you don't correct them unless they are -4. And if they have astigmatism, it should be 3 cylinder or more to correct them. He also make the kids in one group from 4 to 6, and then more than 3 diopter to correct hyperopia, -2 diopter and more to correct myopia and astigmatism anti-cylinder. For the school years, highest plus to give best correct visual acuity with hyperopia, lowest minus to give best corrected visual acuity with myopia, and you correct all the cylinder to give them the best correct visual acuity according to their demand. This is if no, this is the no of subjective under over. So if you want to do over or under with the hyperopia less than +1, for myopia you subtract more than 0.5, and for the astigmatism we don't undercorrect or take any. We should be all the correction of all the cylinders. So always the subtract should be, or the undercorrection would be with the spherical amount, but not the cylinder. You give the cylinder all the time. That's this schedule if there is no sign or symptoms, or if there is no strabismus. If you have a strabismus, then the number will be half, like age 1 to 3, hyperopia with strabismus, then you correct them if they are more than 2.5 diopter. If they are myopic with strabismus, then it's going to be -2 diopter to be corrected, and so on. So that's a short schedule. Again, you can take a short, shots, so it will be helpful for you. Okay, so we already now we decided to give the child the prescription, and we consider the factors that we talk about: the strabismus if the child have, the anisometropia, hyperopia, the myopia, and now we decided and we write the prescription. We write the prescription for the child. So if you give the child the prescriptions and you give them the glasses, then you need to have allowed time for the adaptation for the glasses. Okay, so give accurate refraction and then follow up the visit after 6 to 8 weeks to allow time for spectacle dispensing and for the child to adjust to them. 77% of their problems of the refractions will be solved with the glasses only. So correction of refractive error alone often result in improvement in visual acuity, especially with anisometropia. So we have to give the child time to adapt to the glasses and see what's going to be the result on the next visit. According to the result on the next visit, you're going to decide your plan of the treatment. So if they come to the next visit and they have other problem, find out, then you take you rearrange your management plan to solve the problem that the kids have when he come. But as I said, 77% of them will have corrected with the glasses only. The other things that you consider if you prescribe, you give the right fit, which will increase the compliance of the glasses. The child will, it's an important yet underestimated part of prescribing glasses for children, is choosing the right frame and lenses to encourage regular wear. So the size of the glasses, the material of the glasses, the fitness of the glasses, the strap that they wear, because these glasses will be the part of their identity for a long time. So you can tell the parents that they should share the children and make them pick up their glasses, but it will be under the supervision of the parent and the optometrist or the opticians that in the optical shop, because the child could just pick up something that impressing them. However, the parent and or the opticians or the optometrist will find that it's not suitable for the child, it's not going to fit his face. So it should be a balance between the parents and the child to get the proper glasses. And I think it's better if you put it in your on your prescription papers where you write plastic lenses, compact lenses, and so on. So your prescription should also have all this direction or for the optometrist or for the optometry that work or the optician that work in the places. And there is a lot. This time it's thankfully a lot of different type of prescription or glasses or style of the glasses in the market, so that it's easy for the parents to check up what is best for the child. But you have to direct them and give them announcement and explain to them what is should be suitable for the child, so they can be ready to choose the corrected one. I have catalogs for different type of glasses in my clinic, and I open it and show them what I mean and what I want, what's the type of the things that need. I show them also that the nose bridge, and I show them also the flexibility of the chart, so that they understand exactly what I want for this child according to his refraction or situation of the refraction, because sometimes the child could need compact lenses, the child could need I will change I'm planning to change the glasses in the next visit or the next follow up, so I can explain to them that they don't need to put any anti scratches or or any type of fancy things on the glasses, because maybe in the next visit we'll change that lenses. We will find that the child need more or less, or we need to change for any reason when we see the child on the next visit. So that's very important regarding the glasses. Again, you told the parent that they need to have special frames designed for them, not the small adult ones in the shop. They need, if the cases, you need to give them a special frames for their cases, such as the albinism, the aniridia, the cobloma children. You can explain to them that they need, such as for the albinisms, they need a dark glasses because of the glare that they have from the sunlight. And don't forget the safety and the sun protections. So they should have a shatterproof or impact and anti-scratch protection on the glasses, because the kids will throw that glasses everywhere, and they will come to your clinic with a scratch lenses that they are not able to see through. So you have to explain to the parent all about these things to consider when they are doing the frame for the child or picking up the frame for the child. You will have a special situation need a special type of a prescription, such as when the full correction, such as near esotropia. So you give full correction, but does it not restore binocular vision at near? The child still have some esotropia at near. We call it the one that we call it residual esotropia, or because they have a convergence excess, high AC ratio. Then you need to give them a bifocal. But when you give the bifocal, you need to consider have a special consideration regarding this, and you need to explain to the parents also. You're going to use the bifocal, so you're going to aim to correct that near esotropia, or take it at least to less than 10 prism diopter at near, and that's acceptable. But if it's more than this, then you're gonna need to add more until you get out of that near esotropia. And then you evaluate the child after the adaptation, and you see if is it enough for that, and the esotropia is gone or become less at near. If not, then you can add more of the ad. And then you need also to be careful to adjust the bifocal strength and adjust the bifocal height. Okay, if the infant and toddlers, preschoolers, the infant and toddlers and preschoolers, the near ads should be bisect the pupil, so that we force them to use the near section of the lenses when they look at near, and you can change it with the older kids, 5 to 7 years. You can put that section or that line at the bottom of the third of your pupil. And the 7 years old, when they are now understand how to look through that glasses, you can make the level of that section at the bottom of the pupil. So we have to be careful with the ad when we give it to kids, because if it's not adjusted as proper as we need, they may not benefit from it. But if they have a straight eye at distance and still have some ESO at near, you need to give them that bifocal. And again, you have to try to cut that bifocal or that power every visit they come to. So you cut 0.5 and see does the ESO or the ortho still there and at near, then you can take that 0.5. If not, you keep it. And so on each visit, you should try to cut some of that ad until you help the child get out of that glasses, or you want the child to develop the accommodations ability by himself. So if you give him a full correction or a full ad, you will stop that accommodation and the child will rely only on that ad. So you have to give a maximum ad without, a minimum ad without affecting the near or the esotropia, without, seeing the esotropia at near. You can have accommodative dysfunction for the child. There is no refractive error, but won't be able to read the chart at distance. So that maybe there is accommodative problem. Their focus is locked up at near, and they can't adjust back and forth between the distance and the near. So their accommodation is stuck. You need to rule out accommodation dysfunctions by using the suitable methods, such as the monocular estimated method, retinoscopy. And then you give them lowest plus and lowest cylinder for best visual acuity. And then you may give them a progressive glasses to help the eye adjust more easily from near to far to help them. And they give them also vision therapy to improve their coordinations and focusing ability. Again, we need to be careful regarding the progressive glasses. We need to check each time they are coming and try to reduce that power of plus and be sure that they are doing their exercise that you give to them. You may have amblyopia therapy, you may have amblyopia case. So again, if you want to give glasses, you have first to eliminate the amblyopigenic factors. So if the child have a cataract, they should do the cataract. If the child have strabismus, then you try to correct that strabismus by using the glasses. The glasses at first line going to be at the first line management for that amblyopia. So you give full and balance, especially if it's a esotropia present. You give them full correction, and then again you give attention to convergence and the accommodation during their prescriptions. I know that dealing with amblyopia is a long story and it's complicated. We may have a lecture regarding amblyopia method or treatment in the future, but this is the main point now. You follow them up to 4 to 5, maximum 4 to 5 weeks. You consider measure their binocularity when they come to be sure that they are doing fine. And then you give them a best corrected visual acuity. And always when you do the visual acuity, start with the amblyopia eye, because if you start with the good eye, the child may get bored and he refuse to do the other. So you always start with the good eye, I mean the amblyopia eye, to get their visual acuity, and then you can do the other eye to be sure that it's still it's in a good situation, because sometimes the other eye could be affected and becomes amblyopic also. So we have to check every visit to be sure that there is no reduction in the visual acuity on the good eye. Doing the patch for them is going to be very difficult. Again, you can give the parents the direction and explain to them. And I found it that taking that seriously is very important when you talk to parents about the amblyopia. They don't see what's going on. They don't see what's the patient. That the child in front of them is okay. There is no problem. You can see on the child. So they will not be that careful unless you explain to them how is serious that problem. Sometimes I scare them and I said, the child will not be able to drive the car. The child will not be able to go to the medical school. The child will not be able to be soldiers. And this way they will understand what I mean. So sometimes I be serious with them and give them something to scare them, so they will follow up the direction I want to give for them. They're seriously. I use this refining method to make them follow my management procedures and help me with the kite. I found it also very helpful for them to give them that chart to see that the image here or the picture of the eyes, because sometimes the parents make mistakes and covering the good eye instead of the, I mean, sorry, the good eye instead of covering covering the amblyopia eye instead of covering the good eye, because they think that the amblyopia eye is the problem. So why we are covering the good eye? We need to cover the good eye, the amblyopia eye as a treatment for that one. So they don't understand. So you have to be careful and draw or give them something that telling them you have to cover the right eye or cover the left eye, so they would be knowing the correct eye that they need to cover. You may have aphakic children. You want to give prescription for the aphakic children. Those children have high induced hyperopia. They have vision distortions and difficulty with their task. They have astigmatism. It's again through astigmatism. They have blurred vision, distorted perception. They may have absence of accommodation, so they have difficulty focusing and they have visual discomfort. They may have near esotropia. So their binocular vision has a problem, and with the esotropia, they might have a cosmetic concern. The parents have a cosmetic concern, also they have a high SAA ratio, so they have excessive convergence and potential for the strabismus. So we have those kids have different or many factors going to affect your refraction correction decision. So initially you prescribe their near correction as a single vision. So you give them a full near ad, so because their life is their life is going to be near around them, so they don't concern about the distance. So you give them a full single vision to see, and then in the few first months you overcorrect them by 2 to 3 diopters so that they can get the see near very clearly. After 1 year, after the age of 1 year, you overcorrect them. You reduce the overcorrections to 1 or to 1.5 diopter, because you want them to see near and intermediate distance. And then when they reach the preschool age, you're going to give them a bifocal prescription for distance and intermediate and near lenses. And I found it's best to give them a contact lenses for that aphakic, especially if the power is very high. You can consider contact lenses for the parents. Yeah, but you have also to consider the parent hygiene and the parent concerns. And if you think that parents they will not take care of that contact lenses, then you don't advise them. However, if you find that the parents are very concerned and they're taking the problem, they think seriously, you can recommend the contact lenses for the child. And again, you have to explain for them all the things that related to using the contact lenses and how it should be preserved clear and how inserted to the child's eyes and so on, and how to take care of that contact lenses of the time. So it's a big story for them, but if they want to use it, I think it's going to be a good choice for that affected children. If they wear the glasses, you have to explain to them that they should be aspheric lenses and the lenticular design. It should be high index lenses, and if they pick up the frame, should be lightweight frame for those kids. Sometimes you may have single eye patients. So again, you give them the best correction for the best visual acuity in the good eye. And for cosmetic things, you're going to give them equal lenses, lenses for both eyes, so that there going to be no difference between the them. And then you insist or explain to the parents regarding the importance of wearing a protective glasses, especially during the activities. And the glasses should be impact-resistant lenses, and they should have UV protection. They have anti-scratch, anti-reflective coating, and lightweight frames when you explain to the parents. So it's very important to educate the parents and explain to them what you want for this special condition or special situations child. As we said, patient education is very important. The parents going to play an active role in ensuring their child follow the treatment regimes and wear his glasses constantly, leading to healthy visual development, better visual outcomes, and a smoother adjustment to spectacles. So parents are very important. They are your empowerment for the treatment for doing the treatment regimes and wearing the glasses. It's very important it's very important to explain to them so they will make the child wear the glasses all the time. They can explain to the teachers in the school about the situation and monitoring the child there. They can give the monitor and the reward for the child by giving them, by encouraging things, saying that if you do this, I will give you that, and so on. They will take care of their concerns on the school. They will they will force the regular follow-ups, and you give them a chance to address any misconceptions regarding the cases if they want, and you can give them methods or procedures to instilling healthy habits for the child with that glasses. So they can, for example, they can put the case of the glasses on top of the desk next to the bed. So when the child take off of his glasses at bedtime, you put it inside the glasses. How you clean your glasses, how to wash it, how to be careful when you put the glasses. So all these healthy habits, you can explain it to the parents, and the parents will explain it to the child, and then you will be sure that everything is in a proper way for the management of that child. That's a summary of the things that we said. So I put them all in one chart. You can take a shot of that. If you talk about the glasses from the refractive side, so hyperopia, and I put maximum power, which still give the patient optimal visual acuity, how you're dealing with them. In case of the myopia, how you deal with the myopia, how you deal with the exotropia and esotropia, and if you need a correcting of the need. So I put them all in one chart for you to make it easy. We talked about that on the other. This is the glasses prescription from the point of the strabismus. So exotropia, esotropia, how to deal with astigmatism, myopia, hyperopia, and then if the child have esotropia, how to deal with the astigmatism, myopia, hyperopia, and high ACR ratio again with the near add. So again, I will summarize it in this chart. You can take a snapshot of take a shot of the screen if you want. And this is also from the point of isometropia and isometropia. Again, when to correct. If it's anisometropia, then more than 3 diopter. If there is isometropic refraction, then more than 6 diopter, then you need to correct. So again, that's summary of what we have said in the lecture. This is summary of some of the cases. It's like, I think it's 50% of the patients will be with this scenario. So I'm gonna talk about this scenario for you. It summarizes all the things that we have said before. Let's say the child come to your clinic, he has hypermetropia plus esotropia. You will give them, because he has hypermetropia and esotropia, shows there's a strabismus, then we will give the full cycle correction for the kid, and we may overplus him because we want him to get out of that esotropia. We want to control the accommodation so the child get out of that esotropia. We relax the accommodation. So let's say we give the glasses the kid, okay, with the correction. So he came to you and sent him for home for like 4, 5, 6 weeks, and then you see the patients. You will find that in the first, if you find that he's ortho, that's fine, distance and near, then we are happy of the glasses. You try to gradually decreases that amount of plus because we want him to accommodate by himself. We take plus 0.5 and we see, is this gonna help? I make any difference? If it doesn't make difference, everything is okay, ortho, near, and distance, then we cut this 0.5. If no, it's the child is not responding, then we put it back and we give the child follow-up 3 months, and so we will do the same each time. Since the child is ortho and distance and near, we are happy, and we're gonna do this is each visit until we reach to the point of the refractions that is suitable for the child with the best visual corrector. The aim is we want the child to do accommodation by himself. Let's see the child came to you in the next visit, but he have residual esotropia. He still have some esotropia. Esotropia is less, but he still have some esotropia. Then you may do a refraction because maybe your refraction was wrong at the first time. So you can do a re-refraction and double check your refraction. Be sure that you give the child the proper refraction he need. Maybe you make a mistake in the first time, and it happens. Sometimes it happens because the child was uncooperative, the child was sleepy, something like that. And you may overplus him and see, is this gonna get out of the esotropia? If not, maybe the child have amblyopia, then you try the amblyopia as the guideline of the treatment of the amblyopia and according to his age. If not, then the part of that residual esotropia need a surgery. Okay, so we just do a surgery for the part or the residual esotropia the child have. So we'll transfer him to the ophthalmologist for the surgery after you finish your management treatment. Let's say he came to your clinic with ortho at distance, but he has esotropia at near, then we will check giving him the bifocal and see if this is going to help him. The aim is to make him straight at near or less than 10 prism diopter of esotropia at near. If not, then the surgery will be the solution for those 2 cases. Okay, so most of the kids will be with this scenario. Let's see let's see that the child come to your clinic with myopia and exotropia. Okay, so again, we will, because he has exotropia, if it's a myopia alone, then there's going to be something else. We may correct or under correct, sorry. But if you have exotropia now, we will give a full cycle correction. And also we may over minus him because we want that accommodation to be there to make that exotropia less or make the eye straight. Let's say we give the glasses, the prescription for the child, and we give him a time for adaptation, and he came to our clinic after 4 to 5, 6, after 4 to 5, 6 or 6 weeks. Now he's ortho, near and distance. We're happy. Everything is nice. And then we try to gradually decreases because, as we said, we want them to accommodate by themselves. And then if everything is fine, then a follow-up after 3 months and so on. Okay. However, let's say he came to you in the next visit and you find the residual exotropia. Again, we said we do our re-refract because we may do it longer in the first time, or there's something goes wrong during the examination. So we re-refract the child. We try to over minus him, not more, approximately around -1 diopter, and see maybe that exotropia will go. If not, then that a residual exotropia need to be done, treated with the surgery, and you transfer the child for the ophthalmologist to do the surgery if it's needed. And you explain your point in the file for the ophthalmologist to understand what's going on. Let's say he came to your clinic, ortho at distance and exotropia at near. Again, that child have a convergence insufficiency. You need to do exercise to get out of that near exotropia. There is no other solution other than the exercise for that convergence insufficiency. Okay. So we finished now from lectures. We're gonna have cases, and we will go around it one by one. But first, I want to see if there's any questions regarding the lecture. And thank you very much for being patient with me and attending the lecture. Thank you very much. If there is any questions, Dr. Lema, before we start the cases?
Okay. Yes, we have some questions from the chat. We have from Ms. Sana. She's asking if child 4 years old and have +4 but have exophoria, how to deal if the vision is 6/6 with no symptoms?
+4, that's +4 is within the normal range of the refraction at that age, but it's a symmetromization. He has deviation?
He
No
has
deviation?
exophoria.
Exophoria with good control. We may undercorrect the child. We may undercorrect because of the exophoria. Because exophoria sometimes the child could lose the control and become manifest. So we have to deal with this. Again, as I said, it's a trial and experience. You give some of the correction and see what's going on. If the exophoria is too large, you are afraid that sometimes it could be break and become manifest, then we give a refraction and but undercorrect them because it's the age of the maturization, and the range or the correction or refraction is again within the range of the child age, but the problem is the esophagia. Okay.
Yes, I totally agree with not correcting the child at this age. So the next question is with Mr. Muhammad. What are the potential benefits and drawbacks of using vision therapy to treat learning-related visual problems?
Well, the literature or the cases that we see on the literature, it's very satisfied because it shows that the exercises and the orthoptic management could help. So it's a big benefit, but it's a long story. Again, it needs a long hours of working. It needs a long hours of follow-ups, coming back to the clinic each times, and you don't. Sometimes you don't trust the child doing or the parent doing the exercise or the treatment in the house. So it's a long story, but it's rewarding when the child do that or the patients do that exercises or the management or the orthoptic management. It shouldn't be only exercises. It could be using other type of things that help the child with the convergence or accommodation problems.
Okay, another question. What about myopia control instead of partial correction?
Well, the myopia control is still under study. I mean, if again, I said it's a trial for you. Again, according to your experience, if you see that the myopia control can help you, you can go with. But as I said, it's still under trials. So I don't do it for the kids. Honestly, I do the partial corrections and follow up the traditional method because. I don't want to say it, but my concern is the future of the child. So I don't need to make experiments on the child. And honestly, I will go for the treatment that I find or know that is effective rather than following a trial things that still under observation.
Okay, so you do not agree with going by the myopia management at this age?
Yes, because they still have a metrobization process. We don't know what's the end point of them. They may be, let's say, -4 at this time, but when they finished or reach the age of 5, they are now -2 now. So I don't want to interfere unless we need to interfere. As I said, strabismus, anisometropia, high refraction, low vision, then we will interfere. But if it's nothing there, then we will wait. We will wait and see what's the result. And it's not that long. It's about like up to the age of 5. Then you can jump and do whatever you want after the metrobization process.
I think that answered the question. We have another question from Miss Manahel. Why don't we prescribe blue cut coating for the children?
Blue cut coating?
Yes.
Sorry, I don't have any knowledge about this thing. So if someone can explain to us what's that, and then I will give the refresher. So what's she meant? What she meant? Do
She
you know
means
that?
the blue cut coating that's used for the anti-reflective coating for the screen use.
Okay.
Do
You
you
mean
recommend using this for pediatrics or not?
Honestly, the literature or the results on the internet, if you go on and check the literature, it's you can give it to the child. But again, as I said, it's not that big of helpful for the kids. It's all about that metrobization method and all about the refraction amount. So you don't see, well, we'll put the protections on the screen so that child will be okay. Sitting in front of the screen for the child most of the time it's another problem. Okay, so recommending code screen on the I really I didn't read about this very much, so I can't have exact answer or accurate answer for you, honestly.
I think we're done from the questions from the chat. We can proceed with the examples.
Okay. Again, if anyone want to answer, it's just okay. I don't have a problem unless they want to finish and get out of their refraction. We're gonna go step by step and see the answer of them. Okay. So we have a 7 years old is seen for his first vision exam. He's ortho near and distance, and with refraction reveals a -5 diopter both eyes. So would you prescribe for him, and why? Can we see the answer on the sheets on the slide? Can the answer of them can be seen?
We can see it in the chat box. If they're answering, please proceed answering through the text.
Can we see I can't see it. Can you put it in the screen? Can you read it for me? I can't see it. Can you read it? So I open the chat. If I open the chat,
Yes, it's
okay.
in the chat. We have some people answering already.
Okay, let's see. MashaAllah. Under correct, then fall after 6 months. Minimum correction was best vision. Okay, so we give corrections. You agreed that we give a correction for the child. Okay, all of you agreed. Let me close the chat and go back to the screen. Okay, so most of them you agree that we give a prescription. Yes, we give the prescription. Why? Because it's a school age child, so we don't care. We don't concern about immaturization. And the child on this age need a clear image at distance. The child has a significant myopia. We said significant high myopia should be corrected. So yes, we correct the child because of that amount. So the management will be full cycle correction. We give him minimum lens for best visual acuity, and then we monitor that frequently. However, we have to be careful regarding the progressions of the myopia. Okay. Minimum correction was best visual acuity. Yes, thank you very much. Good. That's right. Okay. it's a school age child, you can do subjective refining with that age. So 7 years old, you can do subjective refining for him on the next visit if you want. So you can do cycloplegic this time, or you can do the subjective refining first before the cycloplegia, and then you do the cycloplegia, and you compare the result of the subjective. And this is what I do. I don't give them a cycloventilate and send them home and then bring them back again for subjective if they are old enough. I do the subjective refining first, and then I will put the drops for them, and then I will compare the subjective and the drops. So in this way, I will spare the child from coming for the subjective next visit, and I give them the class and the prescription according to what I find. Okay, so the next case, 6 months old, is seen for his first vision exam, ortho, near and distance, with refraction refills -5 diopter in one eye and -1.5 diopter in the other eye. So would you prescribe and why? Dr. Alima, you can read
Yes.
if they agreed or not, or they're going to get prescription or not, and why?
I believe this age is a bit tricky for some people, so it's interesting to see them answers. Until now, we don't have any answer. They're being
No.
quiet. Since they heard about 6 months, everyone became quiet now. Okay, yes,
there is a
so
trick things. This is very important point here. You should consider. Okay.
Okay, so we have some people agreeing because of anisometropia,
Exactly.
partial,
That
partial to avoid amblyopia.
exactly.
Yes, full
Yes,
correction.
he have an isometropia, so that's a risk factor for amblyopia. So we don't concern about the age and the ametropization, because we have a more severe problem that yes, going to affect the ametropization rather than the so yes, he have a significant anisometropia, the high risk for amblyopia. The management will be under corrected cyclo because he's 6 months old, so that we're gonna maintain that maintain the ametropization not affected, and then again maintain the difference between the two eyes. So if you cut, let's say -4, you give him a -4, then you're gonna give him -0.5 in the other eye. Okay, if you undercorrect them. So you have to maintain the difference between the two eyes. Never, never, ever give something else. If you reduce, you have to reduce the same amount from both eyes. Okay, and then we monitor the child until he reach the age of that we are be very and if you have amblyopia, then you start your patching therapy as guided on the amblyopia treatment method. Okay. A 4 years old now is seen for the first time again. Main concern is eye tan, so he have an eye tan. However, the eye exam reveals intermittent exudations, so he have an exudation with refraction of us +5 diopter both eyes. He's 4 years old. He have an exudation, intermittent exudation. So would you prescribe for her, and why?
Okay, please start submitting your thoughts.
Okay.
Okay, so we have minimum plus.
Okay, so we will give a fraction because he have
I have exophoria, and then
yes. So
some
there is a
people say
strabismus.
full correction of cyclorefraction because of the strabismus. No prescription, just exercises. Undercorrect. Undercorrect. Okay. They need the correction, maximum correction, give undercorrection. High hyperopia can worsen the deviation, but minimum plus. Okay, so we have different thoughts on this one.
Okay. So yes, she has hyperopia and exudation, so which is uncommon. Hyperopia and exudation, we say it's uncommon. So we have to be careful regarding this condition. We may also think to transfer the child to the neuro to check baby, because they may have other problems, because hyperopia and exudation is not common. Okay. We need to stimulate accommodation, as they said, and convergence. So we under correct cyclo, we give maximum visual acuity and monitor frequently. And as I said, we need to transfer the child to the neuro for checking if there is any hidden things that we don't know about. Okay. Sorry. So that would be the management for this case. Again, another case, at 2 years old, seen for his first vision exam. Again, main concern is eye term. So we find that he have intermittent exodeviations, but with refraction give us -3 diopter, both eyes. So would you give the child refraction? Glasses, sorry.
Okay, they recommend under correction by 1, give minus lenses, full correction, no correction, full correction if remaining over -0.75.
The one who said no correction, you should consider the exodeviation. Then we have the strabismus. Okay.
Okay, have quite a lot of
Agreement
people are
with it.
agreeing on full
Okay.
correction.
Yes, she has a myopia and exodeviation, so we need to correct him. We need
Yeah,
to induce accommodation so that the
activate
exotropia will
accommodation.
be less, and we need to induce convergence so that
Yes.
exodeviation will be less.
We have
So
a
the
perfect
management,
answer from Dr. Mahsan. Yes, to
mashallah.
activate the accommodation and full
Good
correction.
job. Thank you. So false cyclocorrection, we may overcorrect the blast to control the exo with a maximum, with considering also the visual acuity to be a maximum. And then we monitor frequently according to the management. So we said if the child has younger age with higher refraction, the interval of the visit will be closer than the one that has a low problem. So at 2 years old, seen again for the first exam, no eye turn, refers with refraction, and we find that she has astigmatism, so +1 diopter. Hyperopia was -3 astigmatism. The other eye +0.5 and -3 astigmatism. So would you prescribe for him and why?
Okay. Due to strabismus, full correction, normal to her age,
We have no strabismus,
astigmatism only,
only astigmatism.
just the cylinder, prescribe only the cylinder, under correct the
Uh,
cylinder only. So most of the people agreeing on the cylinder correction
so
only.
we give that said we were not concerned about the hyperopia because it's a low amount of hyperopia and the child still in the emetropisation process. So he has hyperopia and astigmatism, so we're going to correct him. He has no strabismus, so we under or no correction of hyperopia. And then we may partially correct the astigmatism by like 3/4 of the correction. And then next time we see if we can give them a maximum amount of that refraction. Okay. Good job. Management, so correction to maximum visual acuity. And then again, you should monitor the child frequently. Good job. Okay, this is another case. So we have a 3 months old seen for the first time. So all your patients are new patients. No deviation. Okay, so we have no strabismus. A wet refraction refills +4 both eyes. And he's 3 months old. So what you prescribe and why?
Okay. Monitor, no prescription, no normal with age, no RX is needed, no
Thank you very
correction.
much. So
Okay.
Safa, I'm happy. My message is reach the people.
Yeah.
So
I believe it's 100% agreement on this case.
okay. So no, the child still through the development process. Good job. And her word is still up close. Okay, so we don't care about refractive error still within the normal range for this ages. You have +4.5, which is normal for that age. We said they have between +2 to 4, and maybe sometimes up to actually 6 diopter. So we don't give anything, but we need to monitor and follow up this child maybe in 6 months to check what's happening with her. Okay. And also 3 months is the child still the muscles movement and the concentration reflection and the fixation reflex still not yet very developed. And then it could be the reason for what the child has. So we're going to wait until everything is settled down and then see what is the end of the management, the end of the process, and then we deal with the end or the result of that end. Thank you very much. That's good job. Okay. A 7 example, 7 age, 18 months. Now that's very I think no one will answer. 18 months old is seen for his first visit exam. Main concern is eye tan. So he has an eye tan and visual acuity 20, 100 both eyes. When do cover test, they find that he has intermittent esotropia of 20 prism and the refraction was +3 both eyes. So what you going to do with this child?
Okay.
I'm waiting.
Because of the intermittent ET, we need to relax the accommodation. Under the plus, full correction for accommodation maintenance. No prescription, full correction, full psychological correction, maximum correction.
Okay. Thank you very much for the answer. So, yes, reduce visual acuity to age. According to her, she has 2100. At that age, they're supposed to be 2050 or 2060. She has an intermittent esotropia, so we need to actually relax that accommodation. So the management going to be a full cyclo. We give her maximum plus for best visual acuity, and then we monitor her. We want that esotropia to be relaxed, so we give her a maximum plus for a best visual acuity. So if we increase the plus and the visual acuity affected, then we reduce the plus to have good visual acuity. Again, we send them and make them adapted to the glasses, and we bring them next time and see what's going to be a result. According, as we saw in that chart with the 3 visits, 3 condition or reflexes of the visit after they use the glasses, okay? So if we have a residual esotropia, then she may need add as guided. So we check what the refraction and give her the best visual acuity. I mean, maximum plus for best visual acuity, but we still have some intermittent or still have some ESO at near. Then that's a residual esotropia, and we may think to add to give her an add to get out of that residual esotropia. And as I said, we need it to be either ortho at near or less than 10 prism diopter at near, so that the child will not be the vision of the child will not be affected. And again, we should be careful regarding the ads. The level and the level of the line and the amount of the ad should be according to the case of the kids. Okay, so example 8, age 4 years old, it's seen for his first time. Main concern is an eye turn again, visual acuity 2100 in the right eye and 2020 in the left eye. The cover test revealed the esotropia of 25 prism, refraction is +6 and +3, +6 right eye, +6 left eye. So would you prescribe for her and why? She's 4 years old.
Okay, full correction and patching OS, full correction, full and patch. Give full and plus 1.5 for the left eye. Yes, full correction, maximum plus. Full cyclo.
Okay, most of them. So yes, she has hyperopia, she has amblyopia, she has anisometropia, and she has esotropia. So she has the full package. So we need, we have to be careful. So the management will be full cyclo because we want to relax that esotropia and maintain the difference. If you want to cut, again, you need to maintain the difference between the 2 eyes. But for me, I will give full cyclo. Again, considering the maximum visual acuity and the esotropia. I want esotropia to be straight, near, and distance. And then we see the kids follow up in 4 to 6 weeks. Again, we said 77% of the patients will be much better wearing the glasses. So you give her the glasses and you don't start anything. You don't cover, you don't do anything. No cover for amblyopia in the first visit wearing the glasses. You give them the glasses, they go for 4 weeks or 6 weeks after they take the glasses. You told the parent 6 weeks after they start wearing the glasses or 4 weeks after they wearing the glasses. You bring them back and you check the situation. Well, maybe the visual acuity will be fine with the glasses. You don't need to cover that eye. Okay, but if you find that no visual acuity, maybe the visual acuity becomes 20, let's say 2040 instead of 2100 with the glasses. So that will give you a huge difference on the management. Instead of starting covering 100, you're going to start covering the patients for the 2040 level of visual acuity. So give the glasses, send the child home for 4 weeks after the glasses, bring him back. And now you measure the visual acuity, you measure the the esotropia and see, is the child straight? We are happy. Is the visual acuity improved with the glasses 2020? We're happy and continue follow the patient. But if the patient still have problem with the visual acuity on the right eye, then we now start the the management of the amblyopia, again, according to the age and the recommended guidelines. So we don't patch from the beginning. You don't never patch the child starting unless if you couldn't get anything from the child. You try to do the fraction, you try to get the visual acuity, and the child is uncooperative. You didn't get anything from him. Then you start patching the good eye and waiting for the child to be comfortable with you. Maybe the next visit when he come will be more cooperative, more comfortable. He knows you now, so you can start batch at this situation. However, but if the child is cooperative and you can get the refraction, and if it is fine, and you are sure from the measurement you have, then you don't batch the eye from the first time. You send them to cut to get the glasses, wear it for 4 weeks or 6 weeks, and then when he come, now you check and start your management plan. Okay, if you need patching, then you're going to start patch the child, and then again, we said it's going to be according to the recommended guidelines and according to the age of the child. Okay.
Okay,
That's
there is
little
one question here.
Okay.
What is the maximum period for the first visit?
4 to 6 weeks, not more than this. And for me, 4 weeks. But sometimes the parents said, well, we cannot come. I said, okay, let's make it 6 weeks. You want the child to get adapted to that glasses, and you want the eye to adapt to that glasses, and you want the brain also to adapt to that glasses. The brain will see that the eye is seeing clearly now, then the accommodation will be relaxed, and maybe also the level of the visual acuity is not amblyopic, it's just because of the refraction. So you give them the lenses, and then now he is 20/20 in both eyes. So that's we are happy. But if he come back with the eye still reduced visual acuity, you start from that point. He come to you now with 20/60 in the right eye, or maybe 20/40 in the right eye. Now you start from this point, because treating 20/100 or patching 20/100 is different than patching 20/40. 20/100 you may give them a full-time patch. However, 20/40 you may give them a part-time patching. So that's the difference between giving the glasses and making the child adapted to it. As I said, 77% of them will come back to you with a good result or a good end of the management.
I totally agree.
Just monitor
Yes.
them. Okay?
Yes, I totally agree.
Okay. So let's go to the, so if residual, again, if the residual esotropy after you give them, then you may consider the ad as guided. Okay. That's a 5 years old, seen for, again, first exam. He's orthophoric, so he has no any strabismus. This is his refraction, 0.5 and -1, axis 45. The other eye, 0.75 with a 0.5 cylinder, axis 135. So are you going to prescribe for this child? He's 5 years old. Let's see your answer, please.
Okay, in this case, full correction.
Make me happy, please.
Normal for the age. Yes, oblique. Full cylinder. They're asking about the VA.
Because don't consider the VA now. There's a
yes,
very specific point.
Symptoms.
Good job. One of them answering the good answer. So, but I think that they meant they didn't complete their answer. If they said prescribe, but they didn't complete the answer. Why? Why?
Yes, oblique, no plus. Full cylinder, half correction of symptomatic, mixed astigmatism, full correction, under correction to avoid
So we all
amblyopia.
agreed to give the corrections, but there is a difference between fall or
What to
under. So
prescribe? Yes.
she has an oblique astigmatism, which is a high risk factor for meridional amblyopia. So thanks you very much for the ones who said it's a meridional or oblique astigmatism. So it's it's a risk factor for amblyopia. So the management is going to be a full or a maximum cylinder that can be tolerated. I mean, for the cylinder. For the hyperopia, as I said, 5 years is almost on the borderline of of the metromization. We may give or may not give the full correction for the hyperopia, but the main concern now is the cylinder and the oblique axis. If we want to cut the hyperopia, we should maintain the difference between the two eyes as it is. So maybe you want to give plano and 0.25 hyperopes with the cylinder. That's fine, but however we should maintain the difference. Okay. So we see him after 4 to 6 weeks again. Sorry. You can see that most of the patients or all of the patients, for me, maximum 6 weeks. If I give them any management, I shouldn't send them more than this, especially the amblyop. The amblyop is a maximum of 4 weeks interval between the visits until the eye settle down or the amblyopia settle down or the equal visual acuity. Then I start to rewinding or withdrawal the type of the method that I have, and also the interval of the visit for the child. Okay. So any question? Let's see. Any question?
Okay. Yes, we have a question. Do you recommend using drops for children who do not tolerate wearing eyeglasses, atropine or cyclo, and how many times?
Okay. If you tried your best and you try to reduce the glasses and do your best and the child still not accepted the glasses, and then you can use the cyclobentalate. I don't recommend it atropine because it's strong and you don't want them to have that side effects. It's less with with cyclobentalate. So 1 drop or 2 drop, 1 drops daily for 1 week or 2 week. I think it can do the work, and then you force also enforce wearing the glasses all the time and see. But I will start with enforcing wearing the glasses all the time, trying to reduce it. And I can show if the child is old enough, I can talk to them and explain to them that is for your own benefit. And look at this. I put the glasses in front of his eyes, put different lenses in front of the eye. I will make a trial with him and I make a deal with the child to wear the glasses. I will explain to him, yes, you will not be able to see with the glasses in the beginning, but you will, if you continue wearing the glasses, you will notice the difference in a few while, and then try your best. But if not, then we can use the cyclo drops, and I use it once daily for 1 week, and then we'll bring him back. Any questions?
I believe we can proceed.
Okay. So that's a summary of our lecture. In the absence of strabismus, our decision must be based on magnitude of the error, patient's ability to accommodate, visual needs of individuals, and the risk of refractive and anisometropic amblyopia. So if we have if the absence of strabismus. If we have strabismus coexist then with refraction or an abnormal accommodation assay ratio, then a full cycloplegic refraction should be given, adding bifocals if anisotropia is still at nearby. If alignment cannot be obtained with spectacles, then the residual need to be done corrected by surgery. If the child have anisometropia or the refraction has anisometropia, you have to give a full cycloplegic refraction for the child. So anisometropia, amblyopia, strabismus, all this will make you give a full correction, and you don't think about the ametrobization because those factors will affect the ametrobization process. So we need to correct this for the child and help him to have a clear visual acuity during the ametrobization and during the growing process. Okay, So a good refractive corrections can bring about remarkable changes in the way a child receives his surrounding. So be careful because any decision you make it now gonna affect the child in the future. So during the first 5 years of age, you have to be careful when you give refraction to the child. So thank you very much for that, and I think I take a lot of your time, and that's my reference if you want to see it. So we're here for the questions. I don't have any problem. Any type of questions. Okay.
Okay, so as we conclude, thank you very much for your active participation. I would like to thank all the audience, and a special thank you for Dr. Safia for sharing your expertise with us tonight. And I would like to ask you all to take a moment to fill out the feedback form. We provided a link through the chat section. And again, thank you very much for interacting with us, and have a great evening. And we look forward to seeing you again on our future event with the Saudi Society of Optometry.
Did they
Please,
have any questions?
let me check if there is any more questions. If we have, okay, amblyopia with nystagmus.
Okay. The problem is the nystagmus. You don't know if it's really an amblyopia or the nystagmus itself. Again, dealing with this type is it's a special situation. Dealing with this will be again a trial condition for you. I'm sorry for saying this, but it's really a trial. You try this and try this and you try that, and you will see what is the best for the child. So I'm not gonna again cover the eye and consider amblyopia unless I'm sure that it's really an amblyopia. We give the glasses for the child. We try to position the child in his point of sorry, I forget the fixation point of that nystagmus. And again, even if you try to do amblyopia treatment for them, the other eyes is affected by the nystagmus. So if you cover the eye, the patient, the child will have an intensive or more nystagmus in the other eye. So it's very important to consider. You may give a partial patching or be using a fogging method for patching, but you never patch the eye with a regular patch because you will intensively increase the nystagmus for the child, and you don't know if that is the reduce of the visual acuity from the amblyopia or from that nystagmus movement. You have to do all your best to figure out and then decided to do. But for me, if the nystagmus is high, I don't like to cover one eye because that will worsen the nystagmus for the child, and also he will lose the fixation point that he gets used to it. Maybe it's going to be that fixation point, preferable fixation point for him in the eye that Anna will patch. So it's very difficult to decide it, to patch the child or not. If you try patching the child in the clinic, and you will see that the other eye will go crazy on the nystagmus movement. I hope I give you the answer, make you understand exactly. Another question?
I don't think there are any more questions here. Yes, I believe we answered all or most of the questions in the chat. There are no more or new questions here. So, okay, we have a new question. Do you have time, Dictora?
Yes, I don't mind. I don't mind.
Okay, so regarding strabismus and refractive error, myopia, should we consider best VA first?
Yes, especially with myopia, you should consider best visual acuity. So you give them minimum minus, that give them a best visual acuity. You don't want to over correct them with the minus because you may give them spasm accommodation, or you may shift them to hyperopia and stay a hyperopic situation. So
Myopia
best
with
visual
esotropia.
with esotropia. Yes,
Yes.
again, the same. It's the same.
Yes.
You will give best corrected visual acuity, and with the esotropia, you want to stimulate to relax the accommodation for the child. So you have to be careful with the minus power that you give the child, because this minus power, if it's more than the child esotropia will increase because the accommodation will increase.
Okay, and for the opposite side, hyperopia with exotropia.
Hyperopia with exotropia. Again, we give example. The two example was very clearly there. But hyperopia with exotropia, with exotropia or esotropia? With exo?
Hyperopia with exo.
Again, it's the same. You have to make a balance between the hyperopia and the exotropia. You want to stimulate the convergence, or stimulate the accommodation to make that exotropia less, and treat in the other side, you treat that hyperopia. So again, best visual correct, minimum plus, because you want to stimulate the accommodation and correct that hyperopia.
Yes, and to always prioritize the visual acuity.
Yeah, it's always visual acuity. So you do your best, and then you check the visual acuity. You think that's the better for the child, but when you check the visual acuity, you find that is not. So check the visual acuity while you're doing your best. So giving less minus, more plus, and check the visual acuity. If it's affected, then you reduce until you get the maximum visual acuity you can reach with the child. I know it's very difficult dealing with the children for the best visual acuity, but you try your best to get whatever. As I said, you can also check the accommodation between the two eye by using retinoscope and see what is the reflection. Is it equal between both eye? If there is a difference in the reflection or the reflex, you see it through the retinoscope, that means there is some accommodations going on, and then you have to figure and have to balance it by doing reducing or increasing the power of the refraction. Again, you consider the visual acuity when you're doing this.
Okay, thank you so much, Dr. Safia.
You're welcome.
I would like to ask you all to follow us on our official platforms if you wish to join us for the future webinars. We thank you again for joining us for this interesting lecture by Dr. Safia, and I wish you all to have a very good night. Thank you so
Thank
much,
you.
Dr.
You are welcome. And thank you very much for everybody for being patient and following the lecture. I know it's a very long lecture, but and very heavy lecture. Hopefully, inshallah, you all get benefit from it. And just pray for me. Okay. Thank you very much for all of you.
Thank you.
Thank you, Dr. Lama. Thank you, Dr. Ibrahim, for being assisting me. Thank you very much for everybody. Have a good night and nice dream, inshallah.
Thank you so much.
Bye bye. مع السلامة.